With esteemed professors, I congratulate Professor Dr. Ines for the marvelous organization and the very rich program indeed. Mr. Chairman, I'm really honored to present in front of you. I'm actually a vascular surgeon. I am the Dean of the National Institute of Diabetes and Endocrinology. My talk would be how to construct a reliable team for diabetic foot management. I consider reliability of a team for diabetic foot that should be a team of 20. As an introduction, we all know that we have almost over 171 million cases of diabetes worldwide. That was in 2000. And that almost 366 million cases projected or considered to be diabetics by 2030. 15% of diabetics develop diabetic foot ulcers in a lifetime, and amputation rates up to 53% among these people. Mortality rates is up to 29% when they develop diabetic foot. The mean cost of treatment is very high, and we have to consider it as the leading cause of non-traumatic lower extremity amputation as by the USA. The prevalence and the mean life are to be considered, but of paramount importance, the cofactors related, the neuroischemic factor, the neuropathic factor, and the ischemic factor. Polymicrobial ulcers are to be considered. The reason why I'm mentioning this because upon this data, our team will be constructed. Staphylococcus aureus is a single isolate into 38% of non-gangrenous limbs. Anaerobic infection is common, and 60% are resistant to penicillins. So one limb is amputated every 20 seconds due to diabetes complication. That's why we invited ourselves in our institute to construct this team. Having the previously mentioned triad and the infection and the impaired immunity and the atherosclerosis and the neuropathy and the non-enzymatic glycosylation of the ligaments causing stiffness of the feet, stiffness and neuropathic increasing the mechanical stress on the feet. So these are the team 20. I won't go losing time reading them, but I will mention them one by one and the function. Of course, there is no team for diabetic foot without an endocrinologist, a reliable one to control the blood glucose level, promote wound healing, and thus control sepsis after controlling the blood glucose level, and consequently reduce other complications such as ophthalmological complication, cardiac complication, etc. The vascular team stands for the front line for the diabetic feet, whether ischemic or non-ischemic. They consider salvageability, they consider wound healing, and they plan for dressing, follow-up, and as an integrated team. It's of paramount importance that the vascular surgeon does not stop at the correction of the blood supply, but they should know very well to decide salvageability prior to revascularization, and to consider they themselves how to manage wounds and the protocols of wound management as per the European Wound Management Association addressing the wounds. A vascular lab image is the third team. They are responsible about the ankle brachial index, the ankle peak systolic velocity measurements, as well as the paramount importance to decide the lesion morphology and hence the interventional plan. I cannot go to the cath lab except with these data available, so that's the next team. And of course, post-intervention follow-up is done by the elegant vascular lab imaging, and guided access is now considered to be done mandatory and crucially under duplex guidance. Electrophysiology team, this is very important, EMG, to detect peripheral neuropathy, distribution and severity and response to treatment, and as well as modern methodology of treatment such as Aptiva machine that we do have. For the cardiologists, they are crucially mandatory team member because they decide myocardial infarction, which could be silent in diabetics. They decide the ejection fraction, and last but not least, they give us the appropriate decision whether to intervene for the cardiac or the peripheral catheter in advance, calculating the risk factors of these patients. Concomitant strategies of anticoagulation, treatment, control of common important issues such as AF is a very important role for our cardiologist. Nephrologists is the member of the team, and we cooperate with the National Institute of Nephrology, and we have the protocol mentioned in that paper. They consider the contrast-induced nephropathy, the proportionate and appropriate antibiotic strategies, reversal of negative impact on the infection and sepsis on the renal function. And of course, we're going to anticoagulate these patients. We don't anticoagulate them except after prior ophthalmological assessment to reduce the risk of retinal hemorrhage with anticoagulation. Nutrition is a cornerstone in diabetics who have diabetic feet to control their diabetes and hence the progression and the regression of the diabetic ulcer. So appropriate control of diabetes, of nephropathy, of dyslipidemia, and controlling drug-to-drug interactions is the role of nutritionists as well as the clinical pharmacists. Dose adjustment as well. Then come the wound care specialists or the vascular surgeons who play with dual identity, who care for the diabetic foot care as well as per the guidelines of each and every stage of the wound affection. So they choose the appropriate modern dressing selection. They document the wound in pictures and in words. They apply the dressings and they follow up after applications of dressings. As we all know, modern dressings would be installed for 3 or 4 days and maybe 1 week as a negative pressure wound therapy. Orthopedic is of paramount importance because some of these diabetic patients develop diabetic charcot foot, bony prominence causing these ulcers. They decide the plan of the bone management. And of course, we cannot go without a radiologist who are going to tackle by plain X-ray, by CT scan, and by MRI to detect early bone marrow edema as a signature sign for developing of early charcot foot. Then the labs, we all know the importance of the labs, and you are my professors to decide, but in our lab we have to entail and incorporate all these laboratory findings. Then come the role of a very professional vacuum applicator. The vac therapy is of paramount importance to heal wound, promote granulation tissue, and reduce the size of the wound. The vacuum should be enrolled to promote healing, to promote granulation tissue and wound contracture, as well as increasing the capillary blood supply at the vicinity of the wound or the ulcer itself. Also, we do have an hyperbaric oxygen chamber in our institute. That's important, and we found very good results in bone marrow osteomyelitis. And of course, our black horse is the cath lab. The cath lab should have a DSA, distal subtraction angiography, a roadmap, fully equipped with all tools on shelf, not to be asked for during the operation, and a post-cath lab ICU. This makes a perfect vascular team. OR and anesthesia. The OR is our backbone whenever we have any complication in the intervention, and the anesthesiologist is of special skills. He should perform ankle block to reduce the risk of general anesthesia, regional block, spinal anesthesia, and sedation, and post-operative pain regimen to relieve the pain. This is important that we reduce the incidence of usage of general anesthesia. A plastic surgeon to apply a graft is important, very important, with a skin graft measure and machines. Foot scan and offloading is considered a crucial part, especially in bone sagging, in charcot foot, or bone prominences producing ulcers. This to produce a custom-made insole or wedge insole, or advise the air walker or Optima diab walker. Prosthesis specialist to appropriately choose the prosthesis, and a physiotherapy comes at the end, but very importantly enrolled for early rehabilitation and getting in the prosthesis. Let me show you a couple of cases. I'm sorry for the pictures. They always say heal, never heal, and in case of ischemia with such a heal, horrendous gangrene approaching and encroaching on the bone, we can first start by, is there a pointer here? We first start by revascularization of the wound. Here we have the distal superficial femoral artery nearly completely occluded, then stented. After stenting this, we have a good blood supply. We go for debridement, and this patient's debridement have entailed bone partial calcinectomy. Yet no granulation tissue would announce itself from a bone that have been removed, but from the surrounding of the wound, the edges of the wound, after application of vacuum, we can promote granulation tissue from the periphery to the center. This granulation tissue is further promoted by modern dressings and appropriate care after revascularization. We get our wound day by day advancing until complete closure of the wound. That's a fate that we won't get except with a team. In another case that shows the importance of the issues I have mentioned, and the last case, we have gangrene involving the little toe, but on the other face of the coin, or the dorsum, the plantar aspect and the dorsal aspect are both affected. We can see here horrendous infection in the plantar aspect of the foot. It appears nice and gentle from the surface, but it was severely affecting the patient, inducing severe renal impairment with a creat of 6. So we cannot take this patient, even by our protocol of acetylcysteine and bicarb, to the cath lab. We had to perform prior debulking of that severe infection. That's what we did, and that's what we got after debulking. A horrendous wound, very deep, and in an ischemic limb. Then we started reconstruction of the blood supply. That's the anterior tibial artery, no peroneal artery, and no posterior tibial artery. We have navigated the anterior tibial artery until the dorsalis pedis with the wire inside, the balloon inside, inflating the anterior tibial artery, reconstructing a straightforward inline blood flow to the foot, and that's what we got after revascularization. The wound started to improve. Of course, the reason of debulking before revascularization was to diminish the creat level, allowing ourselves to get to the cath lab and perform the revascularization. That revascularization started to granulate under the vacuum therapy, modern dressings. This granulation kept on a journey of 3 months. This journey of 3 months was building the wound day by day until we during this journey we have to apply various dressings as per the wound infection, as per the wound sloughing, as per the wound granulation, and then the role of the vacuum, as I have mentioned, is very crucial. The wound have been progressing appropriately until we achieved complete healing and a functioning limb as well, that the patient would go for life in a good way after that. Thank you very much.
Thank you very much, Professor. And questions will be later.